Okay. So again, going back to that term misallocation. Misallocation can be secondary to either over-ordering, ordering stuff that's not necessary, ordering it the wrong way. So instead of doing something as simple as perhaps a meter dose inhaler, no, we want to go ahead and do an SVN. The time difference is tremendous between the two, and the outcome is exactly very, very similar. And the other one, the real scary one, is the failure to order, where there's something that is needed, some intervention from a respiratory care practitioner that is needed, but it's not being done. So different ways to do, but basically they're all classified under misallocation. We talked about protocols before, and we know that they're basically ways for the respiratory care service to be applied to the proper patient at the right time until it's no longer indicated. 4 primary protocols that we'll talk about in this course. One for oxygen therapy to determine the proper amount of oxygen being delivered, reduce the amount of myocardial work, reduce the work of breathing. Volume expansion to either treat or prevent a consolidation or an atelectasis developing. Pulmonary hygiene to help remove secretions. And airway dilation, all over here, sympathomimetic, beta-adrenergic. Oh, I can use those words, and you know what I'm talking about. All those different agents that we can administer to be able to accomplish that. Some of the modalities that we may end up seeing for oxygen therapy can be any kind of an oxygen delivery device, like a nasal cannula, through a mask of various types, and something that we'll talk about, scoop. Volume expansion, just simply having the patient cough and deep breathe. Having the patient do something called incentive spirometry, where we use a device to give them feedback on how deep of a breath they're taking. And then using things like IPPB or CPAP or PEEP to be able to increase the volume of air that is in the lungs at the end of an expiratory phase. Pulmonary hygiene, so a ton of different devices on the market, and we'll play with a lot of them in class. The vest is one that I always encourage people to put on because it's the blast. Just don't let Amber run the controls. One of the things that physical therapists do is they do some, where there's some crossover, they do some chest physical therapy or percussion and postural drainage also. So the PTA program, they were covering that module, and Amber took the vest over to go ahead and demonstrate for them how this device works. And she kind of didn't have it set up right, and she put it on the person and turned it on, and a little high. And then airway dilation, I think Lori talked about yesterday, all the different devices that you end up having, MDI, SVN, DPI, SPAG, whatever. So they're all based on, again, evidence-based medicine, so hopefully there's some rhyme or reason why we're using this. It's not just some what we used to call a bunch of old guys sitting in a room making stuff up. We want the patient, we want it patient-focused so that it's, as the patient's condition changes, our interventions change along with it. But it's going to be based upon the fact that we have to have the ability to properly assess and make some decisions along the way and modify along the way. Again, the key elements, the biggest one is a knowledgeable therapist, and that's one of the reasons that there's pushback from the physicians. They don't feel that we're properly trained in patient assessment. It needs a very strong medical director. You need some doc at the top to help you out and push it through, as well as the administration and the nursing staff. Again, we have to have knowledge as far as the disease pathology. That's why you're taking 1140. The clinical manifestations, patient assessment, things we're doing in here, and we did last fall. And then looking at all the different modalities, what's going to be right for that person at this point in time. There's examples in your packet as far as different type of cheat sheets or algorithms that are there. So we may see something that says clinical manifestation is wheezing. So what's the cause of the wheezing? Well, if the cause of the wheezing is because of an upper airway, a stridorous kind of a thing. Well, it's totally different than if it's lower airway indicating asthma. Or if it's unilateral wheezing, we may need to think about a foreign body aspirate. So all wheezing isn't simply solved by giving albuterol. Duh. And if it is bronchospasm, then we know we have to do some airway dilation therapy. If it's caused because of secretions, we need to go ahead and do some pulmonary hygiene. And if it's a tumor, there's nothing we're going to be able to do about that, right? No matter how much albuterol you give you, you will not shrink the tumor. There needs to be something else going on. So once the protocol is selected, we need to evaluate the appropriateness. When is it time to stop it? Do we need to restart it? And also looking at the severity as far as the clinical manifestations and whether they're able to tolerate it. Some examples of the oxygen therapy protocol out of that book called Egan, and basically they're just step-by-step things. In most hospitals, if they have a protocol, it looks exactly like that. If you see this, do this. And again, it's just up to us to do the proper assessment by using either our physical assessment skills or by using diagnostics like pulse oximetry. The flow chart, you'll learn to love them. Yep-er. And again, the physician can be contacted at various points. There's certain times where there's what we'll call panic values, that if a certain blood gas value is above or below a certain point, we need to make sure the physician is physically contacted, not just left in the chart and not just left up to the nurse. If they have a need for greater than 50% oxygen or a peak flow that's less than 30% are predicted, those are all signs of severe interventions that we need to have more so. So again, these are all examples of where you want to alter, not necessarily alter the protocol, but you want to make sure that the protocol is emphasized. So consult services, we talked about prior. It's an assess and treat, where instead of writing a specific order for respiratory care services, they say, you know what, come on up and take a look at this person. And what we want to do is be able to identify the risk the patient is at. We know that certain clinical manifestations or certain interventions, like surgery, is going to impact how well they breathe. Not a knee surgery, but certainly an upper abdominal surgery, a gallbladder surgery, not going to want to take as deep of a breath. So using this, we can scale it from 0, where it's basically there's no, that intervention or that risk is not there, through to a 4, and you can basically just go through and circle which one is for that specific patient. And then we generate so many points. That total number of points gives us an idea as far as the risk the patient is at. Then, based upon that, we can go back and also assess some other physical findings and be able to, again, score the points to determine the total points as far as what priority and how they're going to be triaged. So is this somebody that we need to make sure we see every 3 hours, every 2 hours, or is this somebody that we just need to check in on once a day? And that's that triage score that you end up having. Then we can say which of the protocols do we need to have. If I know the patient's hypoxemic because their pulse oximetry reading is low, maybe they need the oxygen protocol. If during my assessment I'm hearing coarse crackles that aren't cleared effectively with a cough, maybe they need some bronchial hygiene protocol. So based upon what our findings are, that's going to drive what intervention needs to be done, which protocol needs to be done with. And then we'll list the current therapy and what therapy is recommended, and we'll go back and assess it. Always want to make sure that what we're doing has an indication, because something harmful can happen if we do something just based upon a blind order. So the whole idea of documentation is to be able to have an idea of how this process flows. Again, this is all the evidence that we need for proper communication. It's also used for insurance purposes. It's also used for quality assessment, whether or not we're doing these correctly. And legal issues also. Typically, the electronic chart is what you're going to be finding. Paper chart would probably only in this day and age be used if the computers went down. But usually there's, if it's a computerized medical record, you'll have either different tabs for the various areas or something along that line. And there's other examples there. But again, in the age of medical records, there's not papers to be found. The nice part about electronic medical record is it's accessible by anyone, so that if we do a pulse oximeter reading, it's entered in there. If nursing happens to do a pulse oximeter, it's also entered in. So everyone can see what everyone else is doing, and it hopefully streamlines care. So again, typically we're using a 24-hour clock. If you're documenting, you can document with any color pen. It really does not matter. It used to be in the days when we photographed paper records, certain color ink didn't copy as well as other. In this day and age, that's not an issue. And again, we're not using paper records anyways. It's all electronic. And again, brief charting, but being concise, saying as much as you can in a few number of words as possible. A lot of the electronic charting is nice because it's all click, 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 click. And the example is if you don't document it didn't happen. That's partially true, but not entirely. You get a little scenario there. The student reasoned that because he did not observe any adverse effects following the therapy, he knew the treatment was in fact given. Didn't have to worry about documenting it, and that's obviously not the case. If you're doing free text as you're typing it in, make sure that you're not giving an inappropriate impression as far as what happened with interactions with others. Don't criticize. Always just report the facts, not any conclusions that you may end up having. And again, the dynamic as it's changing. We also know that it's protected. It's a protected information from the HIPAA legislation. It's also the property of the institution. We know that the Health Insurance Portability and Accountability Act is the name of it. It's portable in the sense that they can keep their insurance if they change jobs, and prevents insurance companies from dropping people with pre-existing conditions. We know all this from before. There's a privacy rule, something called protected health information, that basically says that this has to be not disclosed, or a mechanism by which others who are not entitled to the information can get their hands on it. And we'll talk a little bit about that. If you've been to the doctor, you know that there's they always give you when you check in what your rights and responsibilities are. So that's something that is required. The communication is anything can reasonably identify the individuals considered that protective health information. We're going to watch a short video, and in the back, correct me if I'm wrong, there should be, keep going, there's right there, there's something that says HIPAA compliance, okay? At the end of that packet, there's a little test, and I'm going to give you a Scantron, and if you can go ahead as we're going along, and most of the answers you can find as we're going through this. Yep, those are the questions. Should just start. Okay, maybe not. There we go. Unknown DVD. That's what I wanted. Since Bird isn't here, we can't put it in Spanish. We'll have to do it in English.
Tess found out from a friend of hers at the hospital that this was Jerry's second heart attack. I guess I'd better think twice about making him a senior partner.
I happened to take a peek at her chart when the nurse left. Did you know she's HIV positive?
Ever since I got out of the hospital, I get calls all the time from people wanting to sell me their brand of medicine. Think there's a coincidence?
She told me she thought he was weird. They said he got her address from her medical records.
By now, you're familiar with the Health Insurance Portability and Accountability Act, or HIPAA, and the privacy rule that affects your work. To you, this rule may be another item in a long list of procedures to remember. But to patients, an unauthorized disclosure of information could be life-altering. Information placed in the wrong hands could jeopardize patients' reputations, job security, or even their personal safety.
Today, you'll learn the guidelines for using, disclosing, and guarding protected health information, or PHI, through several real-life scenarios. Pay attention. Your compliance with the HIPAA privacy rule could mean the world to your patients. As you know, the HIPAA privacy rule restricts the use and release of medical records and gives patients more control over how that information is used. By law, healthcare providers, health plans, and healthcare clearinghouses, what HIPAA calls covered entities, are now held accountable for privacy violations with serious penalties for non-compliance. In this program, you'll hear the term Protected Health Information, or PHI, used often. PHI is any portion of the medical record regarding a patient's physical or mental health, healthcare services, or payment that contains personal information. Personal information is any information that matches patient to record, such as name, address, social security number, or physician notes. According to the privacy rule, patient permission or authorization is required before using or releasing PHI. However, the rule was not meant to get in the way of prompt and effective health care. There's a certain amount of use and disclosure of PHI that just goes with the territory. HIPAA calls it incidental use and disclosure. Communication and caregiving go hand in hand. HIPAA was not intended to stop you from doing your job. You are required to make reasonable efforts to safeguard patient privacy, activities many of you already do to protect the privacy and dignity of your patients. It's common sense for many. When discussing patient care with other professionals, try to avoid public areas or elevators. If that's impossible, avoid using the patient's name. When you're talking to patients, draw the curtain and try to avoid being overheard.
You're also expected to limit the amount of protected health information you share to the minimum amount of information necessary to get the job done right. This requirement, called minimum necessary, is a basic premise of the privacy rule.
Your facility should have systems in place to limit access to PHI based on who needs it to care for the patient. The rule doesn't apply to treatment. That's a given. Healthcare providers need access to the entire record for treatment. In most other cases, you're expected to limit use and disclosure on a need-to-know basis. Now let's see if you can identify permitted uses and those that are not. This nurse and doctor are discussing a patient in a public area. However, they are speaking quietly and not using the patient's name. Therefore, this action is permitted. What about this hospital employee who wants information about a friend? Not permitted. This employee works in purchasing and does not need access to his friend's PHI to do his job. Special computer screens can be used to prevent anyone from reading information unless he or she is directly in front of it. Some screens can automatically log off if a terminal is not used within a set time frame. This chart is sitting unattended outside an exam room. Permitted or not permitted? You're correct if you said permitted. You can still maintain patient charts at the bedside for monitoring purposes or outside exam rooms with patient names on the chart. Make sure hallways holding charts are monitored and leave medical charts turned toward the wall. You can also post key information such as high fall risk or diabetic diet on patient care signs at the bedside or on the door. This nurse is in a public area and is calling a patient about a scheduled appointment. The action is permitted as long as the nurse limits the information she discloses, especially when leaving a message. For instance, leave your name and number when confirming an appointment, or ask for a call back. If a family member or friend answers, you are permitted to disclose limited information regarding patient care as long as it's in the best interest of the patient. This is a common sight, a sign-in sheet for patients, permitted or not. This is a permitted use, but limits sign-in data to protect privacy. For instance, don't include a space for the reason of the visit.
Can you imagine if you had to get written permission from a patient every time you use the medical record for treatment or billing or daily healthcare operations? It could be a nightmare. For this reason, the rule does not require patient authorization for treatment, payment, or healthcare operations.
You are expected to limit the amount of information shared, except, of course, when it comes to treatment. Let's review some examples of these permitted uses. Healthcare providers talking about their patient. Permitted. A secretary scheduling a surgical procedure. This is a permitted use for treatment. Using PHI to file a claim for payment. Permitted. A nurse faxing a copy of PHI to a specialist who needs information to treat a patient. This use is permitted as long as she takes steps to make sure that the information being sent is received by the intended person only. For example, this nurse called the office first to verify the correct fax number. She also made sure someone was standing by to receive it. There are other times when the minimum necessary PHI can be shared without permission or authorization. In the interest of public health and safety, for instance, to control and prevent disease, to report victim abuse, and to monitor the safety of FDA-regulated products. For health oversight activities to ensure quality of care. For certain law enforcement purposes, and to comply with a HIPAA investigation.
PHI can also be used or disclosed for certain purposes as a limited data set when all personal identifying information has been removed. Your privacy policies detail these exceptions. Make sure you follow them.
For all other uses, a signed authorization from the patient is required to use or release a patient's PHI. Let's look at a few examples. Patient authorization is required for use and disclosure of psychotherapy notes about private counseling sessions. With some exceptions, authorization is required before using or disclosing PHI for marketing, which can include anything used to encourage recipients to purchase a product or service. Selling patient names and addresses to third parties is one example where you would need authorization. If you're informing patients about services of specific benefit to them within your facility, such as a weight loss class, referring a patient to a specialist for a follow-up test, or recommending alternative therapies for treatment, it is not considered marketing. Finally, patient authorization is required for research purposes, such as clinical trials, except when a waiver of authorization is obtained from the Institutional Review Board or a privacy board. Remember to document it whenever you get a signed authorization and keep it on file for at least 6 years. There are circumstances when authorization is not required, but you need the patient's agreement to use or disclose PHI. For instance, to inform family members or others involved in the patient's care, to maintain your facility's patient directory, or to inform agencies during disaster relief efforts.
For patients, and that includes each one of us since we all have medical records, the rule means we can now make informed choices about how our personal health information is used.
Patients can now find out how their medical information is used and request a history of non-routine disclosures. Non-routine disclosures do not include disclosures for treatment, payment, or healthcare operations, or those that were authorized. They can examine their personal medical information and request copies and corrections. They can receive your facility's written notice of privacy practices. They can also request restricted use and disclosure of their PHI, although your agency is not required to agree in all cases. As a healthcare provider, it's your job to make sure your patients can exercise their rights. For instance, patients have the right to inspect their PHI without explanation as to why. And there are no limits on the number of times they can make a request. However, you do have the right to ask that the request be made in writing. Remember to document requests from patients for copies of PHI and all other requests, and file them. Patients are not permitted to access psychotherapy notes from their private counseling sessions, or information compiled for use in litigation. Use your professional judgment. If you believe the information could cause harm to the patient or endanger staff or anyone else, you do not have to agree. If access to PHI is denied, you are required to give the patient a written explanation of the reason and a description of how the patient can complain to your facility's privacy officer or directly to the Department of Health and Human Services, HHS. Basically, the privacy rule asks healthcare providers to give patients a Miranda, a reading of their rights, in written form. It's called Notice of Privacy Practices, and it outlines your facility's privacy practices. The notice includes a statement that your facility is required by law to maintain the privacy of patient PHI and lists patients' rights over their own PHI. The notice also states how patients can exercise their rights and make complaints. It's your job to make sure you understand the privacy practices fully and to make sure patients have a copy of the notice, no later than the date of first service delivery. In emergency situations, provide notice as soon as the emergency is over. Make a good faith effort to get the patient's written acknowledgement of
or patients who choose to designate another to act on their behalf.
In these situations, someone else has the authority to make healthcare decisions. Examples include the parent of a minor child, a court-appointed legal guardian of a mentally incompetent or otherwise incompetent patient, or someone with legal authority to act on behalf of a deceased patient or his or her estate. In these cases, a designated personal representative acts on behalf of the patient and exercises that patient's rights. The personal representative may inspect the patient's PHI or obtain an accounting of non-routine disclosures. All the rights normally exercised by the patient apply to the personal representative. Sometimes legal authority is limited to specific healthcare decisions. For example, a personal representative may only have power of attorney regarding use of artificial life support in a medical emergency, and therefore only have the right to the PHI needed to make that decision.
How can you be certain someone is a personal representative? Well, the same way you've verified representation in the past. State laws determine patient representation, so HIPAA doesn't address this.
Now, let's look at situations involving personal representatives when use and disclosure is permitted and when it is not. This parent wants to inspect her 10-year-old daughter's medical record. Permitted? Yes. A parent does not need to explain a request to see a child's medical records, although in some cases you may need to verify identification. Parents of a minor child are by law the personal representative with the authority to exercise their child's rights, unless a court grants authority to an adult other than the parent, or unless prohibited by state laws. For example, some state laws maintain that parental consent is not required for an adolescent to obtain certain mental health services or medical procedures. If you suspect that the personal representative has subjected a minor or adult to domestic violence, abuse, or neglect, or if you believe disclosure to the representative could endanger that patient, the rule allows you to decline disclosure. This man is asking to see his wife's medical records. This use is not permitted, since the patient's husband does not hold power of attorney, nor is he legal guardian. If the patient is present and capable of making decisions, get the patient's agreement first. It can be an oral agreement, or give the patient a chance to object. If the patient is not present or hasn't agreed prior to disclosure, or in an emergency, use your professional judgment to decide whether disclosure is in the best interests of the patient. For instance, relatives or friends who accompanied a patient to the ER can be given information about the patient's progress if the patient is incapacitated.
You might think of HIPAA as just regs, but it's actually a federal law, with civil penalties of up to $25,000 per year and criminal penalties that can escalate to $250,000 for conspicuously bad offenses.
There are systems in place to make your compliance with HIPAA easier. Your facility has a designated privacy official who's there to help you follow the privacy rule and to assist with any questions or concerns. The complaint process, which applies to patients, employees, or anyone else registering a complaint, is outlined in your facility's Notice of Privacy Practices. You're required to document all privacy complaints as well as their resolutions and keep them on file for 6 years. HHS is required to give you and your facility advice and technical assistance and help you work out problems if you inadvertently make a mistake.
You can keep mistakes from happening by taking an active role in preventing and reporting privacy breaches like these.
This transporter is a friend of the patient. However, he is not permitted to use this PHI. This is a deliberate violation of privacy. Make sure hallways holding charts are monitored and leave medical charts turned toward the wall. Here, this same employee is talking to his coworkers about the patient whose records he should never have accessed. If you overhear conversations like this, don't be shy about speaking up or reporting the violation. This woman, the wife of a well-known political figure, was a victim of domestic violence. 1 hour later, a man arrives claiming to be her brother. What do? Use your professional judgment. If a person accompanies the patient to the facility, checking ID may not be necessary. This man is a reporter who gained access to the victim's medical information. This privacy breach could have been prevented if someone had asked for identification. This man asked to see his 7-year-old daughter's medical records. He was denied. Luckily, the nurse he spoke to had been on the floor when the child was admitted with multiple lacerations around her face and neck and severe dehydration. The medical staff believed the child was a victim of abuse. Always use your professional judgment. If you believe that releasing medical information to anyone, even a legal personal representative, could endanger the patient's life, you are permitted to deny access. This patient is asking to inspect his own medical records. However, he has a documented history of mental instability and violence. What do you do? Always look over the person's record before using or disclosing information for any reason. If you believe there is a safety risk to the patient or others, do not hesitate to say no.
Keep in mind that HIPAA is not intended to override your professional judgment or standards of care. HIPAA knows you are the experts on the front lines of protecting your patients. When you do your job and exercise your professional judgment, you protect everyone's right to privacy and promote quality patient care.
Any questions? Okay. Again, the text that is there should help you if there is a question that you didn't see in the video that you need to answer. So at some point before you leave today, just turn those scantrons in.
Okay. It says you can't leave it by the bedside. So they said outside the chart, but they said bedside. So what does that mean? Do they consider when the chart's outside the room, does that mean bedside?
No, that's outside the room.
But they said bedside, and they didn't say anything about you not leaving it, but they said you can put it by the bedside, and she's like, just turn it so you can't see it.
I'm not sure what the question reads.
You are not permitted to keep the patient's chart at the bedside. But I thought they said yes, but then they had it outside the room. Right?
That
Does that
is
make any
confusing.
sense?
They said bedside, but it was outside.
Yeah.
Yeah, I don't know. It's a 50-50 shot. The reason why I'm doing this, by the way, is that before you guys go to clinical over the summer, they want to make sure that you've had some HIPAA training. That's a kind of a ambiguous question.
Yeah.
Let me take a look at it, and I'll find out more about it. All right, let me keep going on my lecture here.
Can I ask one more question?
Sure.
When it says patients may discuss their PHA as many times as they wish without explanation as to why.
Mm-hmm.
Then when they're mentally stable, you can question.
We're assuming that they're mentally stable.
Oh, okay.
So again, it's always limiting the amount of information, the minimum necessary. We saw that in the video. Only on a need-to-know basis. If you don't need it for your job, the guy from purchasing, then why are we looking at the records? And again, we need to make reasonable efforts to safeguard privacy, as outlined. Certain information can be posted, like diabetic precautions, like DNR notices, etc. You can contact the patient using limited information. And a sign-in sheet, again, just limit as far as who they are and if they have insurance or has anything changed. There's no permission necessary for the various things listed here as far as payment and follow-up. It is written authorization is required for release of psychotherapy notes, for selling patient information, and for research. And it can be verbal permission needs to have for some of the other things listed there, especially during disaster. High tech. High tech is another one that people probably are less familiar with. It stands for the Health Information Technology and Economic and Clinical Health Act. It was enacted in 2009, and it's meant to improve HIPAA specifically as it relates to electronic transmission of PHIs. And again, it also strengthens the enforcement of HIPAA rules by clarifying what kind of trouble you can get into. So, things to avoid: giving out your password. Can't believe people still end up doing that. Accessing patient information when you're not authorized. I've known therapists who have been terminated immediately because they accessed somebody else's information. Computer screens, make sure that that you log off them, and certainly not using any electronic recording devices to capture patient activities without their permission, or even with their permission. Best just not to. Again, don't access something you're not authorized to. Don't remove any medical records from the facility. Don't dispose of patient information without shredding. The obvious ones, there's some verbal communication things to avoid. Discussing patients in public areas. Excludes the elevators. That ones make sense. Facsimile transmission. I don't think that people even still use fax machines. Is that kind of like so 19th century? And again, it is acceptable to have the chart outside of the examination room. And then also we talked about the signage. That's a lot of money. I don't know about you, but I ain't got $25,000 laying around. But it's the loss of employment and the loss of license that is going to be the big one for you. And I certainly do not want to be in a federal prison. Thank you very much. I don't look good in orange. So here's an example. He's meeting one of your fellow students for lunch in the cafeteria after a busy clinical day. He says, "You won't believe what I got into. I was taking care of Mr. Tucker in the ICU, and he started to go bad. We had to intubate. Then he coded, and I got to do CPR. So cool." The problem with the picture is it's a public place, right? You mentioned the patient by name. Possible consequences. Well, obviously that student probably be reprimanded, perhaps to the extent that they are removed from clinical and fail the clinical course. And again, everyone should be aware. They call it 200% responsibility. Not only are you responsible to yourself, you're responsible to make sure the other person doesn't make an error also. So it's kind of a full cycle. I keep all this material for 6 years. One of the things we're going to do next time, I'm having them printed now, there's releases that say that you have gone through some HIPAA training. You're going to sign your name tomorrow probably 20 times. It just, every hospital has their own form. Anywhere we rotate through, I have to have you sign their documentation. It's a pain in the rectal tissue. And that's it. Grandpa, you're now a purse. Questions? Okay, finish completing that, and when you're done, go ahead and turn it in, and we'll go from there.